Well, thanks for everyone for being here. We are thrilled to have Patricia Ganz here from UCLA, and I think many of you know her, but for those of you who don't, I'm going to give you a brief introduction. So Patty's a professor of health policy and management in the School of Public Health and a professor of medicine in the David Geffen School of Medicine at UCLA. I think probably what most of us know about her is her role and background in increasing the care and awareness for cancer survivors, and we're going to get to hear about that today. She's really been a pioneer in the assessment of quality of life in cancer patients and has focused a lot of her clinical and research efforts in the areas of breast cancer and prevention. She has served on the National Cancer Institute Board of Scientific Advisors, the American Society of Clinical Oncology Board of Directors, and has also received the American Cancer Society Medal of Honor. She was a founding member of the National Coalition for Cancer Survivorship back in 1986 and has really been instrumental in serving on 2 Institute of Medicine consensus studies. And I think we'll hear about the continuation of that, so we're really thrilled to have you here, Patty.
So thank you. This is a repeat visit to me. It was not Masonic then, but it was the University of Minnesota Cancer Center. Les Robeson had invited me probably 12 years ago or something like that. So it's a great pleasure to be back and be with you. And I'm going to be, it is on. I hope I'm projecting okay. So it's going to be my pleasure to talk to you about cancer survivorship, but I'm going to talk about it with a perspective that kind of sums up some of the work we've been doing and kind of my distillation of where we need to be going in terms of thinking about the biology of the late effects of cancer treatment in survivors. And that is really the coalescence of cancer treatment, and aging as 2 kind of disciplines that really have a lot of commonality and overlap. So I'm going to start out with a case presentation because I'm a clinician, I'm a medical oncologist, and I have a survivorship clinic, which is really a consultative practice, and patients are referred to me. Sometimes I see people early in the course of their disease, and sometimes it's later. And this was a young woman who was referred to me in 2012. She was actually referred by the primary care physician who recently had started to take care of her, and she had been discharged from the transplant clinic because the physician there said, you've graduated and you can just be followed by an internist. So because we had a survivorship program, the internist referred her to me. She was married, she had 1 child, and she worked as a teacher. And her history was that she had had Hodgkin's lymphoma, stage 2B, that was diagnosed when she was 23 years of age. She was treated with ABVD chemotherapy for 6 cycles, and the cumulative adriamycin, which is the A in this regimen, is the drug that we're most worried about in terms of some late cardiac effects. She also received low-dose involved radiation to the chest. Okay, so again, because we know that radiation has long-term effects on the heart, people have been trying to pull back in terms of the intensity of radiation given. So that was all good and fine. And she did well. She actually had a baby after that, and then she had an asymptomatic recurrence that was detected on a PET scan, and that was when she was 25 years of age. And so because of this recurrence, she was treated with high-dose chemotherapy, stem cell rescue, and had full-dose radiation to the chest now at this time, so much more radiation. Okay, you prefer that. Okay, so what are the other past history that's pertinent when I saw her in 2012? Well, she already had high blood pressure. She was on medication for this. She had had premature ovarian failure after she had had the high-dose therapy as part of the stem cell treatment and was on hormone replacement therapy. She had had her gallbladder removed in 2006, and she had already had a right breast biopsy, which did not show anything abnormal, but showed, again, some changes in the breast, and she was troubled by migraine headaches. Some other pertinent things when I did my survivorship consult, her lipid panel showed an LDL that was 150, which was elevated for someone her age. Her thyroid function was normal, and her echocardiogram showed really a marginal ejection fraction and some mild aortic and mitral regurgitation, so some valvular changes. And she had a lot of anxiety. She had a lot of white coat hypertension. And just coming to UCLA, she lives in the South Bay area of Los Angeles, so driving up to Westwood, coming to doctor's appointments after having been transplanted, created a lot of anxiety for her. So what were my consultation recommendations at that time? Well, these were the late effects monitoring that I suggested. She needed close follow-up for her risks related to cardiac dysfunction from both the radiation to the chest and the anthracycline therapy, and she already had a low ejection fraction. So I referred her to a cardio-oncologist. This is a developing specialty now in cardiology, and again, we're very fortunate to have a very energetic young physician who had come on our faculty who was interested in this. For breast health, because of the radiation to the chest and scatter of the radiation to the breast tissue, she needed high-risk screening for breast cancer. And again, I had suggested to the internist that they might want to consider discontinuing the HRT because we know that hormone exposure is associated with an increased risk of breast cancer. In terms of skin health, I recommended that she have close follow-up of her skin by a dermatologist because in the radiation port, we frequently see basal cell carcinomas that occur in these individuals, so that kind of screening was important. I had suggested that she have a DEXA scan to look at her bone density as a baseline because of the past history of the stem cell transplant radiation and so forth. And then for health promotion and prevention, her BMI was a little bit elevated at 26.8. She had the high LDL, and so I was recommending some lifestyle interventions and possibly pharmacological interventions to lower her LDL because, again, she was already showing signs of chronic health conditions that would, in an older person, be consistent or concerning for atherosclerosis. Now, because of the fact that she had a lot of anxiety, I had suggested that she go to our psychosocial center, the Sims-Mann Integrative Oncology Center, for follow-up and evaluation and to help her with this because she clearly had symptoms of post-traumatic stress. So fast forward. So I didn't really know what happened to this patient until she actually contacted me because of the following history. I'll tell you, she had some interval history where she had thyroid nodules, and again, because of radiation to the neck area, we often see both thyroid nodules and thyroid cancer occurring, so she got put on suppressive therapy to help manage this. She had, again, severe anxiety. Her internist had to give her a benzodiazepam to take just before coming up for her visits. In January of 2018, she noted new onset orthopnea when she was lying flat. She was short of breath. She had near fainting episodes, and her echocardiogram now showed aortic sclerosis with narrowing of the aortic valve and regurgitation, and as well as mitral regurgitation and a low ejection fraction. So she was in heart failure at this point in time. In March, she had her regular screening breast MRI, and there was suspicious nodule in the left breast. And in April, she had a cardiac catheterization that showed very severe narrowing of the left anterior descending artery and the left circumflex, and she had very severe aortic insufficiency. And you can see her end-diastolic pressure was elevated at 35. So this is around the time the patient actually contacted me. I had not had any further contact. And she was very anxious because she was being recommended to have cardiac surgery. She was afraid. She'd been on the web. She had been reading the Cleveland Clinic and different kinds of things and getting different opinions, and she wasn't sure if it was advisable for her to have surgery. So again, I kind of refreshed myself with this case, but very interesting. Well, finally, she decided, after talking to a number of groups about her potential cardiac surgery, to have this done at UCLA, and she had the aortic valve replacement and had bypass of those two vessels. And then finally, recovering from that particular procedure, she had a breast biopsy, and that showed DCIS, a very small tumor, and her hormone replacement therapy was discontinued. So this is a long saga to tell you about one case, but this is not uncommon in long-term survivors of Hodgkin's lymphoma. So what are some reflections on this particular case? Well, she's only 46 years old, and she has multiple chronic conditions. Again, probably people about this age in the audience, and I'm sure you're in better health than this young woman. She had severe post-traumatic stress symptoms from the cancer treatment, which were poorly controlled. She actually is a very successful master teacher, I think administrator in her school, but she just falls apart when she has to come back into the healthcare system. She's had excellent co-management by a really competent internist and cardiologist. And again, very fortunate that she had that kind of care, because I think she really would have fallen through the cracks in terms of her management if that had not occurred. And again, she's had major cardiac surgery and a non-invasive breast cancer. So the question really here is this the likely health status of an average 46-year-old woman? And I see the head shaking. This is not the case. So again, this gives you, in this one case, an example of the burden of the long-term and late effects of cancer treatment in cancer survivors. So what am I going to talk about? So I'm going to talk about cancer as being a disease of aging. That is, our risk of getting cancer increases as we get older for a variety of reasons. And aging itself, as we age, we have an increase in the risk for chronic diseases. So those two things kind of go together in an overlap. And then I'm going to talk about some of the evidence linking cancer treatment to the possibility of accelerated aging, and looking at what the manifestations of accelerated aging are in cancer survivors. And then lastly, what are some of the things that we can think about doing? So this is probably not unfamiliar to many of you, but here's 2010 or 11, where we have the baby boomers now starting to, 10,000 a day, turning 65 years of age. And you can see here the most recent estimates are that there are almost about 16 million cancer survivors, and it's going to go up to 26 million by 2040. But this aqua bar here are the individuals who are 85 years or older. So you can just see that's expanding, and here the big group here, 75 to 84. So while, again, if you look at the large number of survivors, many of them are going to be 65 and older in terms of the number of survivors. So this is from a paper. There's obviously a very famous paper on hallmarks of cancer and the things that are associated with this. Well, this is the hallmarks of aging, what happens as we age. And again, I'm not going to go through all of these things that are examples of what happens as we age here. But genomic instability, telomere attrition, and epigenetic alterations are all things that we have in common with cancer in terms of what's going on in the cancer cell and or leading up to the diagnosis of cancer. So you can see that there's overlap in terms of the biology of both aging and cancer. And again, to kind of point out, when does cancer occur? It takes a long time to actually see cancer develop. We see it in younger individuals, but the peak here is up around age 65. And then, as I've already shown you, there are a lot of people who are going to be surviving and then ultimately dying from their cancer. So as we think about the shaping of the population and the large number of individuals, we are going to have an epidemic of cancer just by virtue of people turning 65. And if you think about the good screening tests we have for breast cancer, colon cancer, prostate cancer, and lung cancer now, just because these people are going to be in an age group where cancer occurs, we're going to apply screening. We're going to have large numbers of individuals being diagnosed with cancer. Some cancers not so serious, but some that may be more serious for individuals. And again, you can see that the majority of cancer diagnoses are occurring in people over 65. So there's this co-occurrence of cancer and aging, but there's also this risk as we age, we're going to get cancer. And if we again look at the survivors, the majority are going to be over 65. And if we again look at another diagram looking at not here the age, but how far out people are, here is this aqua bar are people who are living more than 15 years after their cancer diagnosis. So certainly the childhood cancer survivors who are now in their 40s and 50s, 30 to 40 years later, that's one story. But because a 65-year-old person today treated for cancer could well live into their 80s or 90s surviving the cancer, they have time now, if you will, to experience those late effects of cancer treatment, where we see it in the kids because they live a long time after their diagnosis, diagnosis. We're seeing it in young adults, who I'm particularly interested in, as well as even in older adults. So the point that I'd like to make, in addition to the risk of getting cancer as one gets older, there's an increasing risk of chronic or comorbid conditions, and that's exactly what we saw in the case that I presented to you, the 46-year-old woman who now has many chronic comorbid conditions, far outnumbering her peers in what one would expect. And these are all some of the common things that occur with aging and with really organ failure, organ compromise as we live a long time, and that's kind of the contribution of aging to chronic disease. So I'd like to introduce this concept, which the geriatricians really focus on, and they're very interested in not only how long people live, but how long they have healthy years. And so this particular curve, somebody may be alive, but they're not healthy, and they have a decline in their health. And the geriatricians like to kind of make this very narrow and say, well, you're going to die at age 90, but you're only going to have comorbidities for 6 months before you die. Now, that doesn't happen usually. But they are looking at the compression of comorbidity. If instead we keep people alive, you live to 90, but the last 10 years of your life, you have very bad dementia or you have other physical impairments that make you non-functional, your health span has been diminished even though you're alive. So that's what geriatricians are looking at when they push physical activity, keeping mentally active, and so forth, is to try and keep people healthy for a longer period of time and not just expand the length of years that they live. So that's this gap. So the geriatricians also have a concept of frailty, and I'm going to spend a little bit more time talking about this. Is this something that you've heard about before? Okay. So again, thinking about this, this is where people have said, well, I know I can just look at someone and I know they're frail. They're having trouble walking into the clinic. They've got a walker. They're not so sharp. They can't prepare their meals anymore. That's not difficult to figure out, but it's really when somebody's kind of going on that decline and approaching frailty that we'd like to diagnose and pick them up early. And really, this is a decline in functional reserve of many different organ systems. And it can be one organ system or it could be multiple. But if you've watched an aging parent age and pass away, you've seen them go through this process. They have more fatigue. They have much more difficulty functioning. And so that is something that we are beginning to look at in the cancer patient and survivor, and I'm going to be spending time talking about this. So in the cardiovascular health study, which was a cohort study looking at older individuals, they came up with several parameters that you could look at to try and more specifically define frailty. And so unintended weight loss is something very important. So again, older individuals lose their appetite, but they also lose muscle mass. There are things that go on physiologically. So weight loss is very important. Exhaustion, just feeling tired, everything's an effort. And, couldn't get going. I mean, these are the things that we see in our cancer survivors, and I'll talk about this later. But that is very common as part of this frailty phenotype. Low physical activity, inability to kind of get up and go and do things, and slow timed walk that you can actually do objectively, and then weakness in grip strength. So these are things that are just concomitant of aging. And as I'm talking to you, I can see the gloom and doom and depression coming on in the audience. This is now like the 4th or 5th time I've given this talk. It's not a happy talk, but unfortunately I'll have to face getting older. And so this is what our future is. So you have things you can do about this now. I mean, Doug is riding his bike, which is great. Yeah, but you're just working too hard. But anyway, so these are, again, this is just part of living, and I think, we're in a society in which youth orientation really makes it difficult for us to face aging. So I'm trying to get ahead of the depression that you're going to have at the end of my talk. And I think the important thing is that the pace at which this frailty occurs is really variable, but it is the accumulation of all of these chronic diseases that, again, I'm going to tell you are actually increasing the inflammatory load in the body. And my big postulate is, and you'll hear me talk about this, It is that it's ongoing inflammation that injures organs, that leads to damage and reduction in reserve. And that's a normal physiological process in aging. But there's great heterogeneity. You know, when you look at young kids and young adults and how they mature during puberty, it's so variable. And how people decline in old age is also variable. And so, you know, we shouldn't have a fixed retirement age. Some people should probably retire way before 65. And some of us who are over 65 don't need to retire, you know. So I think this kind of variability is very interesting. So this is from that cardiovascular study, and so they're basically saying, well, hopefully we start out life not being frail, but as we accumulate some of these characteristics, we finally get to the point where we say, yes, you are frail, and there's this period of time where you're beginning to develop these characteristics that you would be considered pre-frail. You're starting to accumulate those criteria. And so again, this is commonly used in the geriatric literature. So if we look at this health span, lifespan curve again in terms of the gap, what we see is the person who has these comorbidities or chronic conditions is going to reach this frailty marker faster than the person who doesn't. And so again, if you can narrow that gap, you're going to become frail much later than the other person. So what is the evidence that cancer and its treatments accelerate aging? So here's a study that was done by some of my colleagues, Robin Yabroff, who's now actually at the American Cancer Society, but had been at the NCI, as were many of these other people. And they looked at the National Health Interview Survey, which is a nationally representative sample of people from the population. And there are standardized questions where they look at the burden of everyday life and illness and a bunch of other functions. And so they went and they actually selected a group of individuals who said they had a cancer history, and then they got an age-matched sample who did not have a cancer history. And just to kind of point out here that among the non-cancer controls, only 18% rated their overall health as fair or poor, but about twice as many did who were cancer survivors. And again, this is just a standardized epidemiological question, and we see that there's a significant difference. If we look at comorbidities, kind of health conditions that people were asked, do you have this or not, we can see that about 55% of the non-cancer patients, people in the survey, had no comorbid conditions. Only about 40% of the cancer survivors said that. And if we look going down, we see increasing numbers of comorbid conditions among the cancer survivors compared to the healthy controls without a cancer diagnosis. So again, significant in terms of just the numbers. And then if you look at more functional activities, you know, do you need help with instrumental activities of daily living? This might be cooking, cleaning, doing your checkbook, those kinds of things. And again, increased in the survivors as a problem, any limitation higher in the survivors, and then very severe limitations like bathing and grooming and so forth. Again, more burden in the survivors. And if you look at the actual comorbid conditions that were endorsed, and this particular paper is a great paper because they actually go through specific cancer diagnoses, and you see some variation. But overall, the cancer survivors had more arthritic, if you want, musculoskeletal complaints than the non-survivors, back and neck problems, fractures and bone problems, hypertension, lung problems. And again, these are not large numbers. It's a huge sample, and that's why these are significant, but it gives you a sense of the pattern that might be different. And again, these are older adults. And so what I want to suggest is that the effects of cancer may overlap with the aging process. Here we see more comorbidity, more burden in the cancer survivors, and again, suggesting with age-matched comparison, they have a greater burden. And whether it's attributable to their cancer treatment, I can't say. This is a cross-sectional assessment, but there certainly is an association between a history of having cancer treatment and having more comorbidity. So this is another way to look at this in terms, this was from a a meeting that was held looking at aging and senescence at the molecular level, and these are some of the various things that may be going on as part of aging in terms of stem cell injury and epigenetics and inflammation that I've already talked about as hallmarks of aging. But we know now from a lot of research that the acute treatments effects of chemotherapy, radiation, and surgery and biotherapy lead to acute inflammation. And again, the extreme case now is our CAR T-cell therapy as an immunotherapy where we see high cytokine levels that occur that people have to go into the intensive care unit. But again, lots of prospective studies have shown acute elevations of inflammation after these treatments. And in our studies, where we've been looking mostly at breast cancer patients, the patients who are having multimodal therapy with radiation and chemotherapy are more likely to have higher levels of inflammation and with that symptoms. So this is from a paper done by some of the leaders in childhood cancer survivorship, again, just showing some of the acute effects of various treatments occurring all the way from cognitive changes, cataracts, hearing loss, carotid artery stenosis from radiation and so forth, liver disease with imatinib. I mean, again, we're just showing a range of drugs that all have known toxicities on organs where there may be acceleration of age-related changes. And again, to look at this in terms of the actual aging processes, in terms of telomere attrition, cellular senescence, again, mechanism here, free radical generation for pulmonary and cardiac injury and second malignancies, stem cell exhaustion, and then epigenetic alterations, which may, again, lead to secondary malignancies. So all of these things, while it's wonderful that we're so successful in curing so many people, which I showed you earlier, these are the downstream consequences. And what I'm going to lead up to towards the end of the talk is really, this is not necessarily going to happen to everyone. It's going to depend on the kind of treatment, its intensity, if somebody has a recurrence of the cancer, just like the patient that I presented. But there is something that we often overlook, and that is the characteristics of the person in whom the cancer arises. How much reserve do they have to begin with, and how resilient they are. And those are kind of two concepts that I'd like you to keep in mind. I'd also like to point out another very, very important thing. There are a large number of childhood cancer survivors who are among us. They kind of get mixed into the general mix of patient populations, but there are a large number of them around. And that 15 to 20% of all new cancers are going to be diagnosed in someone with a prior history of cancer. So that's a little over 300,000 new cases of cancer each year that are in people who have a past history of cancer. So that is more than the number of people who get lung cancer or breast cancer or prostate cancer. So this is a high-risk group of individuals. And this was this very nice paper that was published in JAMA Oncology earlier this year, where you can see, again, 18.4% of incident cancers were second or higher order cancers, and more than 25% of those people who are over 65. So you're already over 65, you get your one cancer, you have all of that burden of aging that's predisposing you to getting cancer. We give a treatment that may exacerbate it, you get another cancer. So this is, again, something for us to keep in mind. And if we're really trying to say who are the high-risk individuals who we need to prevent or reduce the risk of cancer in, it's going to be people who are cancer survivors. So what are some of the lessons that we've learned from the study of childhood and young adult survivors? And so I'm going to show you some data from a number of studies. And from the Childhood Cancer Survivors Study, which I know emanated here at your cancer center with Les Robeson, I want to point out just from one paper the issue in terms of the cumulative incidence of severe and life-threatening conditions. And as you know, they recruited a cohort of individuals who had been treated for childhood cancer. This is the group here in terms of the cumulative incidence of life-threatening conditions. And here are the siblings. And again, looking out to 50 years of follow-up. But more specifically, if we want to look at the first condition, the second condition, the third and fourth, these are the survivors. This is the first condition, but you can see all these secondary conditions that are accumulating. And again, for the siblings, again, much lower rates and lower rates of these second and third conditions. So again, whatever the injury that we do with treatment is, it's multi-organ in terms of the kinds of dysfunctions that might be developing. And also from this same paper, you can just see, just as I showed you from the National Health Interview Study, the kind of high-level risk of common health conditions. You can see higher rates of joint replacement, kidney failure, stroke, heart attack, heart failure, and again, some other issues that are not statistically significant but elevated. And again, lung fibrosis, again, suggesting that whatever the treatments that we're giving are hitting multiple organs in terms of injury. And I think it's easy to think about radiation in the heart, that's right in the direct beam, but the inflammation from the radiation is likely to have systemic effects on other organs as well. And looking at the kinds of life-threatening conditions, this is the comparison of malignancies. So again, we see this high rate, 15-20% here out to 50 years in the patients compared to their siblings, cardiac conditions, hearing, again, not that common, but still elevated, vision problems. And in another study from a different group, this is now at Kaiser Permanente in Southern California, where they decided to look not just at the childhood survivors, but at the AYA, the adolescent and young adult, 15 to 39 years of age. So again, individuals who are still going to have a long life ahead of them, but are also having both acute and chronic problems. And they decided to match their cancer patients in their population of patients to individuals without cancer in their healthcare system. And they have pretty good long-term follow-up and retention within the Kaiser system. So again, this is just looking at the cumulative incidence of all cancer types, and again, elevated in the cancer survivors compared to the age-matched unaffected individuals at Kaiser. If you look at breast cancer, the cumulative, this is the cardiac risk factors, not the cancer development, but cardiac risk factors. You can see increased in breast cancer compared to controls, also lymphoma, as we know, leukemia likely related to transplantation, and high-dose therapy, melanoma, and thyroid cancer. We know that the treatments that we give for thyroid cancer don't particularly have an effect on heart function. So again, this is kind of the natural control group that we don't see the effect, but for these others where we have treatments that may have cardiac effects. And this is from Saro Omenian, who's at City of Hope. He has looked at the issue of chronic health conditions in hematopoietic stem cell treatment, and again, looking at the accumulation of chronic health conditions after transplantation increased in those individuals. And if you look at the severe life-threatening conditions, again, still very elevated over the course of follow-up. And again, comparing them to matched siblings, a very substantial increase in the severe and life-threatening conditions. So a variety of lines of evidence tell us this. And again, for the stem cell transplant, this is not just children, this is young adults and older adults as well. Now, Kiri Ness, who's been, again, very prolific in terms of working with the CCSS, has been looking in detail at patients at St. Jude's coming back. These were children treated at St. Jude's Cancer Research Hospital, and now bringing them back for intensive physiological and cognitive assessments and so forth, and has begun to look at these individuals compared to population controls who are healthy and the same age match. And this is, again, this idea of how does frailty occur in the cancer population. And again, this would be the injury or the exposure to the cancer treatment. And if you have no cancer history, you're going to gradually decline in terms of your function. But if there's injury to cells that are trying to divide and repair in various tissues, you're going to have difficulties doing that because of the cancer treatment and have an acceleration of the risk of frailty. And here are data from the St. Jude Life cohort. where she's used the criteria and the data from the cardiovascular health study that I've showed you before in terms of the frequency, percentage of individuals who made a diagnosis of frailty by grip strength, walking time, and symptoms. And you can see in her St. Jude Life cohort, 18 to 50 years old, she, and mean of age of 33, 7.9% met diagnostic criteria for frailty. In the cardiovascular health study, people 65 years of age and older, we have only 7.2%. In her age-matched healthy controls from the Memphis area, none of them were considered frail. If we look at that pre-frail category where you've accumulated some of those diagnostic criteria for frailty, 22% of the St. Jude Life cohort patients met that diagnosis. 15% in the elderly cardiovascular health study made that, and only 6.2 of the age-matched controls from the Memphis area met that. So again, you can see this extraordinary increased burden of pre-frailty and then frailty in the childhood cancer survivors. And these are people who had good follow-up care. You know, they're being followed. Not all of them, but many of them have had good medical care. So frailty in cancer survivors really leads to a decreased ability to function independently, as I've shown you from several different kinds of data. It accelerates the risk for premature death. And again, we see this played out in the childhood cancer survivors because, again, we have a 40 to 50-year follow-up for them, and we can see it play out. We don't see that in a 65-year-old who gets treated. We're seeing it now, I think, in the AYA patient population. The case that I presented, she was 23 when she was diagnosed. She's 46 now. We've seen in that a little over 20 years how that's played out in her as an extreme example. And so again, those highly treated, intensively treated patients are the signal for us, but I think subtle forms of this occur in all of the patient populations that we see and treat. So what are some of the common things that we see in our clinic in patients coming back to see us in follow-up? And these are the symptoms that we see in adult survivors. Fatigue is probably the most common complaint. It's a very common complaint acutely in the post-treatment period, during treatment, but a certain percentage, about 25% of them, will continue to complain of this 2, 3, 4, 5, 10, 15 years later. And, you know, sometimes when you see these people, you say, they must be depressed. You know, how can they still be tired from the treatment? The treatment ended. You know, why are they still tired? So it's real. And it's based on inflammatory changes, based on work and we and others have done. Cognitive difficulties, again, has really kind of been poo-pooed. If you look at the average consent form for a cancer clinical trial, we almost never mention cognitive changes. We'll talk about fatigue, maybe. We'll talk about nausea, vomiting, hair loss, but we don't talk about this. And again, this is, again, a subtle but emerging chronic problem for many patients, and it does, you know, you don't have to be radiated to your brain to have this as a problem. Neuropathy, I think largely because of the introductions of the taxanes, the more widespread use of the platinum alkaloids, and then now in myeloma, some of the drugs that are very significant causers of neuropathy. We are seeing this, and then because we're treating older people who may have pre-existing neural damage already, you know, in one of our breast cancer studies, we actually saw that about 25% of the women entering the trial already had numbness and tingling in their hands and feet already before they got anything. So this is common in the older population and may predispose to more injury, pain, decreased physical functioning, insomnia. So these are many of the kinds of things that I talked about in what's frail, pre-frail in terms of criteria. So let's go ahead and talk about cognitive changes. I've spent the last 20 years really focusing on fatigue and cognitive changes. I'm going to highlight a bit of our own work, but I'm going to talk about other people's work in this area. And typically, you know, what we see in surveys is that survivors endorse having these difficulties, but they actually rarely bring it up with their clinicians because they figure, it just goes with the territory or there's nothing they can do about it. Again, cross-sectional studies of breast cancer survivors again, show that this is common. Many individuals will attribute it to chemotherapy treatment, but we actually see this in people who haven't had chemotherapy treatment. One of the areas we're interested in is looking at endocrine therapy because hormones affect the brain and cognition of women as they age normally, and the anti-hormonal therapies that we give may also have similar effects. And if you look at longitudinal rather than cross-sectional studies, it's the same 15 to 20% of individuals who we see just having persistent, ongoing difficulties. Everybody has cognitive difficulties during treatment because they're stressed. We're giving them sedative medications that may interfere with this. They may not be sleeping well. There's a lot that's going on. But persisting once treatment ends, that's a different story. And I think the important thing to know is that it's not just chemotherapy. We used to call this chemo brain or chemo fog. It's really not just associated with that. And again, as with many other conditions, there may be cognitive deficits that people have before the cancer was ever diagnosed. So that actually tells you that they may not have good reserve in that area. Could be that the cancer itself is producing cytokines or other factors that may be inhibiting cognitive function. So this is a very complex area of research. And what does the survivor really tell us? They'll say, you know, it's just the fine degree of memory or the speed at which I'm able to recall information. So they're not completely dysfunctional, but they notice that they're off. Or when I leave at the end of the day, I am spent when before I was energetic. And it's not physical spent, it is a mental spent that I didn't used to have. And again, we see fatigue and cognitive complaints often co-occurring in individuals. For some people, it's the fatigue that's the big issue. For others, it's the cognitive complaints. Or the patient might just say, I'm not as sharp as I was. I've lost my edge. You know, I went back to work and I can't seem to keep up with what I used to do before. I used to multitask. It was no big issue. I could remember who my clients were. Now I have to write with Post-it notes all over the place. I mean, these are the stories that I'm sure many of you have heard. So this is really multifactorial, and I think, you know, in the early days, we used to think there was direct injury to the brain. So when I started doing this work or started to hear it from patients, this is when we were giving CMF chemotherapy for breast cancer, and both methotrexate and 5-FU actually crossed the blood-brain barrier. So there was some concern that maybe it was actually using these drugs that we knew got into the brain. Certainly in the kids, when they give intrathecal methotrexate, that's an issue for leukemia because of the local toxicity. But we've moved away from those drugs, and in fact, we see this now with almost any kind of chemotherapy. And it is thought that it is really the systemic inflammation from the chemotherapy that we see that then crosses the inflammatory cells, cross the blood-brain barrier, and they activate microglial cells in the brain that produce local inflammation as part of this. And there have been some nice animal models that have looked at this. But when you're really seeing the patient in the clinic and he or she is 6 or 9 months after their treatment, the chemotherapy is gone, the inflammation should have resolved, and there may be other kinds of things going on. They still could have anxiety and depression that may be slowing them down in their function. I've already mentioned the hormone levels. Preexisting genetic factors, you know, does ApoE4 contribute to this? Some studies suggest possibly. And again, the direct toxic effects of the chemotherapy and then the inflammation. The other thing is that sometimes it's the high-functioning patients who really kind of notice they've lost things. So it's a litigator who's used to going into court, being on their toes, or a teacher. I've had teachers come to me and say, you know, I'm just putting on a show. I really can't work the way I used to with these kids. And, you know, they feel bad about not being able to do what they were able to do. So we're talking about subtle deficits. Rarely we see people, certainly people who may get whole brain radiation and chemotherapy. I remember seeing patients early in my career with small cell lung cancer who would give chemo and whole brain irradiation to who had full-blown dementia as part of that. But usually it's much more subtle. And that's why people kind of say, oh, I don't think it's real. So again, there's been an emphasis now to try and rename this and not call it chemobrain, but really talk about cancer-related cognitive changes. And again, very common across many cancers now. So Tim Ollis has written about this quite a bit. He's a psychologist at Memorial Sloan Kettering, and it's the same kind of idea that, you know, we're all on these unfortunate age-related declines, And, you know, if you're on this high cognitive reserve, which everyone in this room is, based on the fact that you have had higher education and you're working at a university, you know, we're going to be on a slower decline than somebody who has low cognitive reserve. We have more neuronal connections and all this kind of stuff. And so the time at which we're going to decline and possibly have our age-related cognitive difficulties is different. And again, you know, if you have cancer, you know, you may be no cancer, you're on this curve. If you're a cancer survivor who has pretty good reserve, you might have a decline that parallels this. But if you don't have good reserve or other things are going on, you may wind up being on an accelerated curve. And that's why, you know, we may have difficulty telling this cancer survivor from that cancer survivor, because this may be the smaller number of people. But again, it depends on what kind of testing you do. And as I'll talk about, probably subjective complaints is the best thing, because the patient and or their family can tell you if somebody's not doing well in terms of what they did before. Their boss might notice that they're not functioning well. And so I think we have to really believe what the patient has to say, just like pain or depression. You know, we listen to the patient. But because this is a field that has been dominated by neuropsychologists who have a tool and a trade where they may give a 2 or 3 hour battery of tests to kind of look at every part of the brain and how it functions, they, you know, kind of say, well, that's the gold standard. But those tests are very sensitive if you have head trauma or stroke or psychosis to kind of select normal from not normal. But for people who are having more subtle deficits, they may, in fact, actually perform okay in terms of neuropsychological test norms, but they're actually high IQ and their function was much higher before, and in fact, there may be some decrement. So some of the imaging tests have actually been more sensitive. So just to kind of talk about what happens with the neuropsychological tests, for all of these in terms of long-term memory and speed of processing, these are all actually getting worse as we get older. We're just not as fast as we used to be, and that's why, you know, as you get older, you know, you're driving on the street, you know, your reaction time may not be as good as you get older. But here, if we look at world knowledge and a few other tests, they're actually okay. But it's really the speed of processing and long-term memory that we most often see affected in the cancer survivor. So again, is it this exacerbation of the normal age-related changes? And if we look at what's going on in the brain, again, a lot of what we see in age-related cognitive decline is thought to be due to systemic inflammation. There certainly could be mini strokes and things like that, injury to the brain, but there are white matter changes that occur and you get reduced neural efficiency. And again, we think that in cancer, we're seeing a recapitulation actually of these same age-related changes. I don't have enough time to tell you all about this, but again, white matter integrity has been shown to be disrupted and noted also in breast cancer survivors when imaging studies are done. And again, what happens when you have this is that you have difficulties doing a memory task. And again, we see this in older individuals. They might get the answer to the memory task in the scanner, but they have to recruit more areas of the brain, pull in. Instead of just one side of the brain, they may have to pull in both sides. We see the same thing in post-treatment cancer survivors, and I'm going to show you this really cool study. This was almost a case report that was presented in JCO a number of years ago. What this group found was that they had a woman who had had chemotherapy and tamoxifen. She was in her 60s. She was 60 years of age, and she actually had an identical twin. She was genetically identical. They worked her up, who had not had breast cancer, and they brought the two of them together for neuropsychological testing, questionnaires, and so forth, and then put them in the fMRI scanner to look at a memory task in the scanner. And at the top, we have the woman who has had cancer treatment with chemotherapy and tamoxifen, and we have her sister, and this is the first question or the first test. And what you see is that the cancer survivor is having to pull in these frontal areas of the brain to get the question right, as well as some of these posteriorly. On the second task, we begin to see her sister recruiting in those frontal areas, again, under the stress of the memory task to bring in. And then here, again, you can see here the patient is still working much harder than her sister. And again, in many other studies of imaging, we see these frontal areas lighting up. So the answer was retrieved by the cancer survivor, but she had to work harder to pull out the answer. And that's what patients are really telling us, that they're having more difficulty. This was a study that we did. This was in long-term breast cancer survivors who we did PET scanning on, and they did a memory task in the scanner. This was the group of women with no chemotherapy. This was the group with chemotherapy. And you can see these same frontal areas light up here, and again, a different imaging technology to compensate to get the answer. So again, I think, we have a lot of commonality between cancer and normal aging. And again, the pitch that I'm making is really that various organs in the body have only a limited number of repertoires to respond to an injury, and that we're seeing this played out in a pattern very similar to what we see in aging. So cognition takes more energy. The patients may experience this as really having to work harder, but they actually may be performing okay, even though they are much more aware of this. So this is where the subjective assessment by the patient is valuable. And again, there's a consistent correlation between mental fatigue and this report of having to work harder and feeling very tired with this. So to talk about a few other disabilities that, again, seem to tell us that we're seeing this convergence of aging and cancer treatment toxicity, this was a study from Oregon Health Sciences where this particular investigator was doing a number of intervention studies for cancer patients to help them recover from cancer treatment. And she had done standardized physical therapy assessments in terms of function of these individuals as part of the research study. And in this particular analysis, went back to see how many of these had persistent symptoms of neuropathy and then correlated it with their function during the research tests. And so what I'm going to show you is that if you look at this single item question for the severity of neuropathy, here are individuals who had a little and here who had very much more severe neuropathy. And you can look at their performance on the physical battery that she gave, and you can see the performance was worse in those who were reporting very significant neuropathy. If we look at mobility, disability, and falls, again, they had been objectively assessed for their mobility, and you can see those who had symptoms of neuropathy were much worse, and those who had falls, again, the proportion of falls went up. And so this is a big issue if we think about falls being a major problem in aging, and now we have people that we've caused neuropathy as part of their cancer treatment. They have a heightened risk of falls. And I know at Memorial Sloan Kettering about 10 years ago, when they had a geriatric cancer P30 grant, P20 maybe, they in fact instituted within the institution fall prevention strategies. They had physical therapists actually going in for their cancer patients. So not only are you worried about acute falls, but obviously chronically what may happen to these individuals. So again, a lasting effect of our treatments that may be coinciding with age-related changes. And then this is a very interesting study that Jan Glazer did at Ohio State, where she was looking at breast cancer patients and controls, women who were coming in for a possible diagnosis of breast cancer but didn't have it, and then followed them all longitudinally. They were seen before the cancer diagnosis was made, then 6 months after the completion of treatment, and then 12 months later. So they're followed out about 2 years or more. And she looked at comorbidity and pain and inflammation in these women. And this is, again, you can see the distribution. So if we look at looking at the Charlson comorbidity score, which is a pretty crude measure of comorbidity, we see the cancer patients, the breast cancer patients, having an increased likelihood of comorbidities. This is now a year after the end of their treatment compared to the controls who didn't have much increase. We look at the pain scale. A lower score is more pain. We see more pain. Again, this is about a year after the end of treatment compared to the healthy women. And if we look at the risk of comorbidity associated with the type of treatment, we see the most intensively treated patients having greater comorbidity than those who have just radiation and surgery or surgery alone. And then if we look at pain, again, pain being greater with more intensive treatment. And here are the inflammatory cytokines. TNF is my favorite cytokine. That's what we see elevated in our studies of fatigue and cognitive difficulties. But you can see it going up post-treatment in the breast cancer patients compared to the controls. IL-6, another hallmark inflammatory marker, IL-1 beta. And if you look at the total cytokines being elevated, and again, this is a year after treatment ends, so being elevated still in these individuals. And now just to show you a little bit of our own work, and again, why I'm beginning to kind of do this convergence of aging and cancer treatment. I had a study which was looking at cognitive function after breast cancer treatment. It was really intensively evaluating women in the first year after treatment, but then I was able to maintain the cohort, and we did annual questionnaires, and then we were able to bring them in for a follow-up visit where they had blood work drawn and had a full neuropsychological test again. And we added some new tests to this particular battery. We had been looking at the pro-inflammatory cytokines. And what we're looking at here, this is now 3 to 6 years later, we're looking at the percentage of women, this is about 100 women, who had high DNA damage. So we were looking at this with the COMET assay. And if they had just had surgery alone, they had low DNA. And then if they had chemotherapy and radiation, it was higher. And then if we looked at the relationship between TNF at this point in time, 3 to 6 years later, and the DNA damage, this is the low DNA damage group, 71 women. And in the high DNA damage group, we have a higher TNF. So again, suggesting an association between persistent evidence of DNA damage and ongoing inflammation. And then this is a second study which was looking at the same group of women, but now looking at their neuropsych test evaluations. And we measured, again, looking at the low DNA damage. You can see these women had pretty good performance. They were above the norm here for these various domains. But if we look at the women who had high DNA damage, they're performing worse than the women without the DNA damage. And again, we especially see this in memory and executive function, which are the areas of the brain that we know are most affected. Again, these are associations. This is not causal, but there's some suggestion that this persistent evidence of DNA damage and inflammation may be affecting this. And then this is another analysis where we looked at telomerase. And again, telomere shortening occurs as cells age, and telomerase activity is important in terms of repairing this. And if we look at the relationship between telomerase enzymatic activity and neuropsych performance, those who have lower telomerase activity are more likely to have evidence of low neuropsych test scores for attention, executive function, and processing speed. Again, suggesting that a marker of aging is associated with poorer cognitive function in these breast cancer survivors who are 3 to 6 years after their diagnosis. So I think this is a very nice model. My colleague Judith Carroll, who's been the person really spearheading some of the aging work in our research group, put this together, and it really kind of talks about how we think about prior history of the patient, these pre-existing host factors that the patient brings to their cancer diagnosis. Not in here, we could talk about smoking, we could talk about alcohol, we could talk about HPV. There are a whole bunch of different pre-existing factors that probably are etiologic in the development of the cancer, but also pre-existing. But a lot of our own work has looked at social adversity and early life stress as being a factor in kind of causing that person to be less resilient, if you will, over their lifetime, and perhaps leading to their risk of cancer. But here we have the chemotherapy and radiation exposure affecting the cell, and then we have all of these cellular processes that, again, are leading to ongoing inflammation. As cells are dying, we're killing the cancer cell with our treatment, but we're also killing normal cells. And we have dying cells that are senescent and give off IL-6 and a whole bunch of other inflammatory factors. And it's those dying cells that are leading to the perpetuation of the inflammation and the symptoms that we've described. And then again, all of these can lead to neuroinflammation, possibly causing the cognitive changes, some of these symptoms, and again, decline in various organs and accelerated aging and the possibility of frailty. So I think this is a really nice model and framework to be thinking about in terms of combining both of these fields. So that's a depressing story. Unfortunately, I don't have too much to tell us about how to reverse these things, but I think there's a lot of evidence, and it's going on in geriatrics right now about health promotion, and we should be doing this across the lifespan of people, not just when they start to have a comorbidity. And we all know this in terms of avoiding alcohol and tobacco, weight gain and energy balance being very important. But physical activity is really very influential, if you will, in reversing inflammation and also probably leading to improved muscle mass, better metabolism, a whole bunch of other things. So very important. We need to monitor bone health. Again, not only are people, ongoing inflammation can actually accelerate osteoporosis, but we have people who are now at risk for falls, so if their bones are not very dense, we need to do something about that. And I think we need to really think about managing these symptoms, which are real and ongoing, for a significant portion, 20-25% of individuals who we see have this. And we have found that many of the mind-body techniques are very helpful. We've done a number of studies with Iyengar yoga for fatigue, Tai Chi for insomnia, mindfulness meditation for younger, highly distressed women. We all always co-evaluate the outcome of the study with biological measures, and we are measuring inflammatory changes, resolving or improving with these interventions, which again leads credibility to their benefit. How they're working, I can't really tell you what the mechanism is, but they are useful. And then again, thinking about our survivors and how we need to manage them, looking for disease prevention and surveillance. I've already told you they're really at high risk for second cancers. We need to be on the lookout for that. The cardiovascular risk factors, and really anticipating and managing these chronic conditions, which means they don't all have to be in the oncology clinic. We need to get a good internist, just like I did for that young woman with Hodgkin's disease. They're on top of things. They're used to taking care of somebody who's older who already has accumulated these particular chronic conditions. They need to do that for the survivors. And I want to mention genetic testing. I can't tell you how many survivors I have seen now that in retrospect, if we do a panel, they actually have a predisposing risk factor for cancer. So that helps us in terms of potentially screening for other cancers, but certainly for their families in terms of prevention. So really what we want to do and want to think about is we're going to be giving people multimodal cancer therapy. I think we need to be smart and give the right therapy to the right person at the right time so we can avoid excess toxicity if the therapy is not needed. But we get this increased comorbidity, and that really, moves this curve to the left in terms of their health span and risk for frailty. But hopefully, with some of the kinds of strategies that I've suggested that really need to be tested and evaluated, we can, in fact, reduce that. So thank you very much. Did you have a question?
Questions?
So,
Patty, how do you separate out the physiologic processes that cause cancer to increase aging versus the treatments we do? And the reason I ask that is because, for those of us who live in a breast cancer world, we're still treating a lot of women who don't need systemic therapy. Even though, we talk about low-risk patients and we give them endocrine therapy only, but if you really crack that apart, a lot of those low-risk patients are low-risk because they're not risk for having distant recurrence, so we're giving a therapy they don't need. So you could argue one way to reduce the accelerated aging is to stop treating low-risk patients.
Yeah, I think if we could figure that out, it would be really helpful, because whenever we look at our adjuvant therapy trials, there's a huge number of people. I mean, if you look at the control group in our old studies, there are a large number of women who never recurred. And if we look at breast cancer as an example, most people are going to die of cardiovascular disease.
Yeah.
So I agree, and this is really the overdiagnosis and overtreatment. At the earlier meeting I was at with the ACS, Otis Brawley was there, and I think it is a big issue for us doing one-size-all treatment for these people, and we need to refine it, and we need to have better strategies to do that.
And I know it's probably impossible to do, but has anybody ever looked back in the older trials where women got nothing or something and asked the question, does the nothing group stay on the top of that curve, or is it the fact that they had cancer and already pushed them down an accelerated aging?
Yeah, I don't know. Again, I mean, I think it would be wonderful if we could get that kind of information. Groups like the NSABP did have a lot of long-term data. I actually was funded with another person, a colleague, to actually look at, we did meta-analyses looking at different trials, and actually the neuropathy paper that I did using the B30 data set was part of that, where we went back to look at baseline symptoms to see who was at risk for a problem. So I know that in the case of neuropathy, this has now been shown in a number of studies, that higher BMI risk for people with diabetes, turned out women who got mastectomy, which is a bigger operation, they all got taxanes in that particular trial. There was a relationship to the dose of the taxane, of course, but there were pre-existing factors that predicted a lot greater likelihood of worsening or persistent neuropathy, and then impairments in terms of quality of life and function. So I think we can actually identify some individuals who have comorbidities that are going to make the treatments worse. And I think, that's one example where I went back to a trial to look at that. We're just funded from the NCI to look at patient-reported outcomes and tolerability of therapy, and I actually proposed within that study to look at some of our earlier trials, one in rectal cancer, the B35 DCIS trial where we had tamoxifen and an AI, and then I think a third trial, I can't remember which one it was, to actually look at the baseline characteristics of individuals and then the long-term outcomes in terms of toxicity. So I think we can pour into those databases, but we don't always have the data that we would like.
I would add to that question, I think to dovetail with that, my question is whether or not you've looked at other inflammatory diseases. If you think of rheumatoid arthritis, HIV, a lot of what we do, we focus on the actual treatments, but when you look at other inflammatory populations like those diseases,
they have accelerated.
They have much of
yeah.
the
Yeah, so the rheumatoid arthritis, cardiac disease is a big issue.
Same thing with
HIV, yeah. So I think, and again, they have high inflammation. I'm worried right now about the immunotherapy. I have a few trials where I'm collecting patient-reported outcomes and blood specimens in the immunotherapy trials because I am worried that those survivors are going to have even more significant accelerated aging. We have the SWOG NRG trial with Pembro versus nothing in the adjuvant setting for triple negative. We have long-term survivor, quality of life we're collecting in there as well as blood. So I think, we have to be very, very mindful. I think the big issue is not overtreat people who don't really need it because of the added morbidity. And then as we begin to cure more people, we're going to have new kinds of toxicities that are going to be a problem.
Based on the inflammation hypothesis and the data on the reported outcomes, I mean, what sample time frame do you think is important in studying survivors? Is it doing lots early to get kind of the trajectory, or would you advocate more?
I think pre-treatment. So we have another cohort study that we did, Julie Bauer, my colleague who's worked on the fatigue piece of things. We had an inception cohort where we enrolled women after surgery. We didn't get them before surgery, but before any chemo or radiation. We were looking at epigenetic changes from pre to post, and we were seeing some accelerated aging. Ned Sharpless, our cancer center NCI director, has done some work with High Mus looking at P16 showing acceleration. So I think to understand the biology and the mechanism, we kind of need these early studies. But I think I didn't, again, elaborate on all the work we've done, but we have actually found that there seems to be a genetic predisposition for persistent fatigue. We find that there are SNPs in the promoter region of IL-1, IL-6, and TNF that predict a greater likelihood of persistent fatigue. So again, and we see people in this inception cohort, the women who are coming into the study who are already fatigued, post-surgical treatment, have a history of fatigue, they have a history of early life stress. We haven't yet looked at the genetics yet, but they may have, again, bringing to the disease what happened. And again, the last thing we've been doing is looking at the tumor microenvironment. We've actually been, again, just recently published a paper where we are looking at the past history of depression, social isolation, and the tumor microenvironment. And this gets to your question, Doug. Are there some predisposing things in the host that are actually leading to the cancer and potentially its prognosis? We hope now to use one of the other NSABP trials We've got quality of life data. We can look at the tumor and look at the microenvironment in the tumor, and then look at the long-term survival. So just to say, we need to have a lot of we need to have a lot of things, because it could not only be the host factors could not only be affecting the experience of the patient clinically, their long-term trajectory in terms of age-related complications, but also the prognosis for the tumor. So to me, this is really fascinating. And I talked to Shannon yesterday from the transplant service, and she's starting to collect baseline data and follow up on that patient population of a lot of fatigue, and that, again, that is a really good case study in high intensity treatment. It's great that you can do something like that. So thank you very much.
Thank you very much.